Our next speaker is Dr. Sumit Mohan. Sumit is an associate professor of medicine and epidemiology at Columbia University. His clinical and research career has focused on understanding health disparities in kidney disease. His goal is to improve access to care and outcomes for patients with kidney disease, as you can see, very much aligned with the work that Dr. Saul is doing. Dr. Mohan currently is the National Faculty Chair for the CMS HRSA ESRD Treatment Choices Learning Collaborative. That's the mandatory kidney treatment model, payment model that many of you are likely participating in. He's also the Vice Chair of the Organ Procurement Network and UNOS Data Advisory Committee, a member of their Policy Oversight Committee, a member of the SRTR Review Committee, that's the data collection system for kidney transplants, and finally, he's deputy editor for Kidney International Reports. With all of that, Sumit, I'm not sure how you found time to fit us in, but I do appreciate your taking the time and joining us today.
Thank you, Jeff. So, I was asked to talk about disparities in kidney disease and transplantation, and as Stuart has mentioned so eloquently, that this is an enormous challenge and a really large problem in the United States. So what I'm going to try to do is give you an overview of the scope of the challenge that we face and some of the things that we're trying to do, but we'll try to do it quickly over the next 20 minutes. So these are my disclosures. I don't really have any conflicts of interest. So chronic kidney disease in the United States is a wide and highly prevalent disease. It infects millions, tens of millions of people. This is data from now more than 15 years ago, where we estimated about 25 million people already had chronic kidney disease. More recently, the CDC now estimates that 1 in 7 adults in the United States, about 14 to 15% of adults have chronic kidney disease. And if you look at just individuals with diabetes, it's 1 in 3. If you look at hypertensives, it's 1 in 5. So it's a fairly common disease, but unfortunately one that is not adequately recognized. So this is data from the CMS inpatient claims data set, which basically shows that when you look at national data from NHANES, which is kind of our national epidemiologic data for most diseases that allows us to estimate the prevalence of non-communicable diseases, in most age groups, in most subsets of patients, there's a relatively high prevalence of chronic kidney disease. But in terms of how much of that chronic kidney disease is recognized by clinicians who are seeing these patients, it's a small fraction, right? So less than half to a third of patients who have chronic kidney disease have their kidney disease recognized by their clinicians. So it should come as no surprise that when you look at patients and their awareness of chronic kidney disease, it's a dismal number. So in early stage of chronic kidney disease, where you actually have the ability to have an intervention to make a difference, those numbers are dismally small. When you get to CKD stage 4, where you actually have much more severe disease and the complication of chronic kidney disease, that number still does go up, but doesn't go up adequately. And of course, if you have stage 5 kidney disease and you're getting ready for dialysis or transplantation, if you don't already know that you have kidney disease at that point, then that's a real challenge. And because it's so prevalent, cost of chronic kidney disease in the United States is rising rapidly. It now exceeds the cost of congestive heart failure management, which has always been thought to consume a large portion of the Medicare budget. So we at this point are consuming between 12 and 14% of the entire US Medicare budget. Chronic kidney disease care over the last 20 years has gone up almost tenfold. And if you look at just inpatient care, that's gone up 5-fold. And so it shouldn't come as a surprise that with this large burden of chronic kidney disease, we're seeing a large and rapid increase in the ESRD prevalence, to the point where we're now starting to approach almost 1 million patients with some form of end-stage kidney disease, including kidney transplant. And this is particularly startling if you think about the fact that the original estimate for the ESRD program, when Congress passed the laws that allowed Medicare to pay for ESRD, the original estimate was just 10,000 people. And the United States is not alone in this. Globally, ESRD trends are rising upwards in most countries where there is good data for non-communicable diseases. And so this is going to be a global challenge that we all have to address. And this is a figure that Dr. Saul had already shown you, but essentially this shows adjusted ESRD prevalence over the last 20 years has been on the rise. But what I would point out here is not just that the rise, but the large racial disparity. So despite the fact that Blacks and African-American individuals make up about 13 or 14% of the US population, they make up about a third of the ESRD population, demonstrating just clearly how much of the disease burden that we face with kidney disease, disproportionately affects minorities. Now, ESRD care costs have been somewhat more controlled, in part because of bundled payments and innovative payment models from CMS. But despite the fact that the Medicare population the ESRD population within Medicare is less than 1% or approximately 1% of the entire Medicare population, we're consistently using about 7 to 8% of the Medicare budget just for end-stage kidney disease. I'm going to switch gears since we're going to try to cover the entire spectrum of kidney disease, talk briefly about acute kidney injury. Okay? So acute kidney injury is like any other form of kidney disease, has significant racial disparities as well. So rates of hospitalizations with AKI have been rising rapidly. There's been almost a 25 to 30% increase over the last 10 years. This disproportionately, once again, affects minority patients. Now, one could argue maybe the disparities are from not so severe AKI, right? Maybe this is just an artifact of the underlying billing data, because after all, as you can see on the left side, AKI hospitalizations that are associated with a nephrology consult are actually on the decline, right? We've seen a 30% decrease in AKI being seen by a nephrologist in the last decade or so. But that's not really the case, right? So if this is data from UCSF and Sue's group, it shows clearly that the incidence of AKI, severe AKI that would require even temporary dialysis in the hospital, has been going up. And in the first 10 years of this century, essentially tripled, right? And even in these instances, there's a significant racial disparity between Black and white patients, with minority patients clearly being more affected than white patients. The racial disparities in AKIs following, a cardiac cath. You could use any example, in fact, for any form of AKI, and you're going to see very similar data where, regardless of what the underlying level of kidney function was, or what degree of AKI severity you're looking at, or whether you're looking at whether they needed dialysis or not, minority patients are disproportionately affected and frequently 2 to 3 times more likely to develop AKI. Now, if it's an isolated event and the patient responded and did well, perhaps it would be less of a concern. But hospitalizations following an AKI hospitalization are very common. So 20% of patients, or 1 in 5 patients who's had a hospitalization with AKI, is likely to have another one within 6 months. A third of these individuals are going to be back in the hospital with another acute kidney injury episode within 2 years. And yet we're seeing less than 15% of these patients within 6 months in the outpatient setting as nephrologists. So we're actually not getting them the kind of care that we think we should. Now, you can say, well, it's an AKI, and what's the implication? Well, the implication is that 40% of these individuals are going to die within the next 2 years. So it's not a mild AKI. It is, it's a reasonably severe injury. It is something that is, a disease state we should be intervening on. 3% of those individuals will go on to develop end-stage kidney disease. And with 40% death rates, you'd imagine that a lot more of these patients, rather than just 10 or 12%, ought to be seen in the outpatient setting by nephrology. Now, if you look at end-stage kidney disease and kidney transplantation, the story, unfortunately, is very similar, and underscores just how much room we have for improvement. So end-stage kidney disease patients have reasonably poor overall survival rate, unfortunately, with a 5-year survival rate of about a little over 40% if you're a hemodialysis patient in center. That number has not really moved over the past 2 decades, unfortunately. Whereas if you look at the red bar, closer to the top of the screen, you'll see that living donor transplants and deceased donor transplants do much, much better than individuals on dialysis, right? Another way to look at it is if you match them to age match individuals who are also on Medicare. So as you can see here, the orange bar are patients on dialysis. Mortality rate's high. It's several-fold higher than the general Medicare population. But the minute you give these individuals a transplant, right, mortality rates plummet within their age groups to start to approximate that of the general Medicare population. That's an unbelievably good improvement in long-term survival for individuals with kidney disease. What's even more remarkable is that unlike in most other parts of medicine, our best treatment option is also by far our cheapest treatment option. It's a treatment option that we should be offering more of our patients, that we should be encouraging more of our patients to be getting. Yet, despite that, the recent kidney allocation changes that are now about 5 years old, have had quite the contrary impact, unfortunately. So currently in the United States, we have lost about 2 decades worth of progress, where we are at the point where we have the fewest prevalent ESRD patients on our wait list. So less than 1 in 8 patients currently is on the wait list waiting for a transplant. And a significant proportion of those, unfortunately, are inactive listing, and meaning that they are not likely to be getting an organ offer anytime soon. And perhaps more disappointing was that we've gone an entire decade with essentially no changes and no increases in the number of transplants that were being performed in the United States. That is likely to be changing. We're starting to see a rapid uptick in deceased donor transplants. So 2020, despite the pandemic, was a banner year for deceased donor transplants. We had 17,000 deceased donor kidney transplants. And so hopefully that upward trend is going to continue. And that's where I think the new payment models that CMS has proposed and implemented, especially the ESRD treatment choices model, is likely to continue to move this needle towards transplant for the benefit of our patients. Now, however, to get transplanted, it's a multi-step process. Even though we have well over 500,000 patients on dialysis, those individuals need to be educated about their transplant options. They need to be referred to a transplant center that then will evaluate them in a multi-step process, bring them to selection, and then perhaps waitlist them. So somewhere between that 500,000 to we have less than 100,000 people on the wait list. There's a lot of attrition. And with no public data available at those steps, it's been a challenge to understand what the barriers here are and what we can do to overcome them. But this is not a new problem. So as far back as 2006, Medicare essentially changed their Medicare registration form for ESRD patients and introduced this question, which says, have patients been informed of their kidney transplant options, yes or no, which is essentially supposed to be a nudge to get providers to talk to their patients about transplant. And yet there was a question right next to it that says, patient, if it's not informed, tell me why, right? With one of the options being the patient's not been assessed. And so that's essentially like a get out of jail free card for clinicians who haven't done this for their patients. Now, unfortunately, this is also does not affect patients uniformly. Clearly, minority patients are less likely to have been informed of their transplant options when they start dialysis. Those individuals with public insurance, Medicare or Medicaid or both, are less likely to be informed of their transplant choices. And those individuals who did not have adequate nephrology care in the lead up to dialysis because they weren't made aware that they needed to see a nephrologist or that they had chronic kidney disease are definitely much less likely. But it's not just at that step. This is data from Rachel Patzer's group, which shows clearly that at every step of the process, there are both disparities and delays, right? And we've since demonstrated that these are easily overcome by providing better education and better navigation of the process and helping patients understand what it is that they should be doing and what the eventual benefit is of successfully getting on the wait list. But I think early intervention is clear. So this is data from Jesse Sholden, our group, that shows clearly that, the further out you get from starting dialysis, there starts to create an inertia in terms of getting waitlisted. So the best time to get waitlisted and the most rapid uptick we see on getting patients on the waitlist is in the first year. And that's what we should be focusing on. And over the past 20 years, we have actually not really moved the needle in terms of getting patients on dialysis access to the transplant waitlist. We have actually probably done a disservice to our healthiest patients. The patients most likely to benefit from a transplant are youngest patients. As a relative proportion of the waitlist, our youngest patients are actually becoming a smaller and smaller fraction of the total waitlist, with increases only occurring in the 60 to 64 year age group and the 65 to 70 year age group. What this slide doesn't show you is that there's also racial disparity here, where it is much more common for a young individual to be African American than to be white, right? Underscoring the fact that racial factors are continuing to impact our ability to get people equal access to the wait list. Another way to look at this, I recognize this is a small, the font here is a little bit small, so let me walk you through this. If you look at adjusted hazard ratios of waitlist placement, if you can look at race, those two blue dots clearly show you that African Americans and other minority populations are at a much lower risk of getting on the wait list. But it's not just a racial disparity. There's also a socioeconomic disparity here. So individuals at lower socioeconomic status clearly have a lower risk of getting waitlisted than those at higher socioeconomic statuses. And this affects everybody. So this is the youngest patients that we have, our healthiest, youngest patients, the ones that are going to have the biggest improvement in life expectancy with a transplant. And even in those individuals, we're seeing within 3 years of starting dialysis, less than half of those individuals get access to the waitlist. And their access to the waitlist is very different based on the income stratification that they belong to. And we have not moved the needle in 20 years more. So this is again data from us that shows clearly that if you look at residential median household income, this is a geospatial analysis where we linked all of USRDS data to socioeconomic data from across the country. Patients in the lowest socioeconomic strata clearly have the lowest access, and that lowest access has not gotten any better over the last 2 decades. Another way to think of it is whether you look at it by race or by socioeconomic status. Clearly, in every particular strata, African Americans are disadvantaged compared to their white colleagues. But it goes one step further. Dialysis unit ownership and access to the waitlist clearly has an impact. So those individuals who are at for-profit dialysis facilities as opposed to non-profit dialysis facilities have a disadvantage in access to the waitlist. They have an additional disadvantage in terms of getting transplanted, even if they get on the waitlist or if they get a living donor, and a significant disadvantage of having a living donor transplant, suggesting that they're just not being adequately informed of their choices or educated about what their benefits would be should they get a transplant. And this is not unique to any one group or any one part of the country. This is data from our group where we looked at the thousands and thousands of dialysis facilities across the country. We looked at over 6,000 dialysis facilities and basically identified the fact that 27% of all dialysis facilities have a significant racial disparity in the patients who are waitlisted and referred for waitlisting for transplantation. Now, we have since intervened, identified a subset of those where we thought there was an opportunity to provide education material, retrain staff. So we've done that in about 700 dialysis facilities across the country and started to narrow these racial disparities, suggesting that can actually be done. But it's not just the dialysis facilities. Even when we look at preemptive transplantation, that is the access to the waitlist before you get on the transplant list, right? So the individuals are being seen by nephrology specialists who clearly understand the benefit of transplant being referred. And what we see is there is both a socioeconomic disparity where individuals who are on private insurance in the lead up to starting dialysis are much, much more likely to be preemptively listed and much more likely to get a preemptive transplant. Similarly, there are large racial disparities where white patients have a significant advantage in terms of getting both a preemptive list and a preemptive transplant. So it's not just the dialysis facilities and their ownership, it's across the entire spectrum at every step. Now, the kidney allocation system didn't completely fail. It was redesigned in an effort to overcome what we know are delays in referring to the waitlist for minority patients. And by design, for those individuals who successfully make it onto the waitlist, there has been a narrowing in those sort of disparities. And so now whites, blacks, and Hispanic patients, for the most part, get a similar rate of transplantation. It's low, but it is similar for those individuals who are on the waitlist. So at least we've had some successes on the waitlist. Disparities persist for living donor kidney transplantation, as you can see here, and they appear to have gotten worse over this time period from 1995 through 2015. This is data from Tangana Purnell's group at Hopkins, which clearly shows that the adjusted risk or hazard ratio for a Black patient getting a living donor transplant relative to a similar white patient has actually deteriorated, right, to the point where we should be concerned about this. Now, in summary, this is more recent data, shows that clearly factors associated with a lower probability of kidney transplant include Black race, include being older, having a lower income, having public insurance, lower social support, but also lower transplant knowledge. Some of these represent structural barriers, but some of these represent knowledge gaps that are potentially modifiable and within the control of us as clinicians to change. Now, there are lots of social determinants of health and kidney disease. Unfortunately, many of them are amplified by racial disparities that we need to be addressing. And so if we're going to improve care for our patients with kidney disease, we have to take a more holistic look. We have to look at these social determinants and see. And there are many opportunities here to intervene and change. So in a 20-minute talk, it's impossible to try to address this, but I would point you towards this fantastic review by Jenna Norton, which talks about what these social determinants are and what we ought to be doing about them. Then finally, I will say there has also been movement on the biology side. Right? So we have multiple grants now that look at APOL1 high-risk genotypes, their association with kidney disease, the barriers and the ethical considerations of looking at genetic testing in the setting of both racial disparities and the fact that African ancestry may be associated with an increased prevalence of certain kinds of genes. And we don't have the time to talk about it today, but I'm happy to answer any questions about this, or if somebody wants to reach out afterwards. So in summary, I've shown you the incidence and prevalence of kidney disease is increasing both in the United States and worldwide. It continues to disproportionately impact minorities and socially disadvantaged populations. And while we have successfully controlled ESRD costs with bundle payments, kidney disease continues to increase in terms of cost and burden to our healthcare system. And so improving how we manage kidney disease is important. We've shown that the low levels of awareness of CKD continues to persist among providers and patients, much to our dismay, and that significant racial disparities exist in all forms of kidney disease and in the access of treatment modalities at multiple levels, but appear to be greatest for kidney transplantation. And I'll stop there. Thank you.